Hello all, in this video we'll be discussing about coagulation failure in pregnancy. So in the previous video, we have discussed regarding the inherited conditions that can cause coagulation failure during pregnancy, that is hemophilia and von Willebrand's disease. In this video, we'll be discussing about the acquired conditions that include disseminated intravascular coagulation, idiopathic thrombocytopenic purpura and anticoagulant therapy. So let's discuss each condition. The first one is disseminated intravascular coagulation. So this is a condition in which bleeding and clotting takes place in the body simultaneously. Okay, so bleeding and clotting is taking place at the same time in a same person's body. So how can that be possible? So it is not a condition that is present only in pregnant women. You might have learned this in your medical surgical classes, that this can occur due to many triggers. So some triggers that will lead to the inappropriate activation of coagulation cascade, which in turn result in the consumption of clotting factors. So there is some inappropriate activation of coagulation cascade due to some triggers which will lead to the whole consumption of the clotting factor. So no clotting factor is remaining, that can result in bleeding. So this is what simply takes place in disseminated intravascular coagulation or DIC. So what are the triggers that is associated with DIC? So there are many triggers, but in pregnancy, these are the triggers. So that include injury to the vascular endothelium due to preeclampsia, hypovolemic shock or septicemia, and other is release of thrombogenic tissue factors. Thrombogenic means those factors that can cause the genesis of a thrombus. So that can occur in placental abruption, amniotic fluid embolism, and prolonged intrauterine fetal death. So in all these conditions, it can trigger the inappropriate activation of the coagulation cascade. So this is a simple pathogenesis, a very simplified pathogenesis of DIC. So these triggers that can cause the inappropriate activation of the coagulation cascade. So coagulation is taking place everywhere in the body, that leads to thrombus formation. So when thrombus formation happens, what happens is the major blood vessels are being obstructed by this thrombus. So that can lead to end organ failure. At the same time, due to the inappropriate activation of the coagulation cascade, there is consumption of coagulation factors. So coagulation factors are absent. So when there is a need, there is no coagulation factor. That can result in bleeding, and ultimately death can result if no management is given. So this is just a simplified pathogenesis. The next one is the clinical features. So we have seen that bleeding and clotting is taking place simultaneously in the person's body. So there can be hemorrhagic manifestations as well as thrombotic manifestations. So the hemorrhagic manifestations include ecchymosis, petechiae, bleeding from gums, hematuria, GI bleeding, and intracranial hemorrhage. Then the thrombotic manifestations that include cerebral infarcts leading to coma and delirium, then vascular infarcts resulting in pulmonary edema, then peripheral gangrene, and acute tubular necrosis. So these are specific to each organ. So when a thrombus obstructs the blood flow to a particular organ, that organ failure is described here. So this is all about the clinical features. Now let's see the management. So management means we have to identify the cause. That is very important in case of DIC. So otherwise, whatever be the management we give, we can't save the patient. We have to identify the cause and treat the cause. Then blood transfusion with FFP and cryoprecipitate, because the patient is bleeding. So we have to compensate for that by giving blood transfusion with fresh frozen plasma and cryoprecipitate. Then once the mother's condition is stabilized, vaginal delivery is conducted. Then we also have to take precautions to prevent PPH. So whatever is the cause, treat the cause and give the symptomatic management. So some of the textbooks say about giving heparin, but when the patient is actively bleeding, we can't give heparin. So that is controversial. So this is all about the management in brief. Now let's see the next condition, that is idiopathic thrombocytopenic purpura. So here the platelet count. So thrombocytopenia means platelet count is decreased. So idiopathic means the cause is unknown. So the platelet count here is less than 1 lakh per millimeter cube. The management is, if the platelet count is less than 20,000 before the onset of labor and 50,000 at the time of delivery, we give IV immunoglobulin and platelet transfusion. So if it is between 50,000 and 1 lakh, there is no need for management. We just keep the patient under observation and give symptomatic management. But at the time of delivery, if it is 50,000, or just before the onset of labor, if it is 20,000, then we have to give this platelet transfusion at IV immunoglobulin to increase the platelet count. Otherwise, the mother will be in severe risk for bleeding. A large amount of blood will be lost from the mother's body. So that is why this condition is very significant. The next condition we're going to see is anticoagulant therapy. That is mothers on anticoagulant therapy. So usually the women who have underwent any mechanical heart valve transplantation, or women with atrial fibrillation or corrected congenital heart disease might be on anticoagulants. You might have seen patients who underwent mechanical heart valve transplantation on warfarin, right? So these women will be in such anticoagulant therapy. So during pregnancy, the thing is that the benefits of anticoagulants outweigh the risk. because if the woman if a pregnant woman stop anticoagulant, she will be at severe risk for thrombus formation and all. So here during pregnancy, the benefits outweigh the risk. So the woman have to continue anticoagulant therapy. But there are some risks also. So the choice of anticoagulant is very important. So warfarin and low molecular weight heparin are the usually used anticoagulants. But the problem with warfarin is that it is very toxic to the fetus. And this warfarin that can cross the placental barrier and that can cause fetal toxicity. So during the first trimester of pregnancy, warfarin is not preferred. Heparin is given. But heparin cannot be used on a very long-term basis. So that can cause that can be injurious to the mother. So that is why during the second trimester, that is from 12 weeks to 36 weeks, we use warfarin. Now you might be thinking why warfarin is used. We have already told that warfarin is not good for the baby. Then why are we using warfarin? That is because by 12 weeks, most of the organogenesis will be completed in the baby. So it will no longer cause any risk to the baby. That's why we are using warfarin. But after 36 weeks, we will again continue heparin. Because after 36 weeks, at any time we are expecting delivery. So if we continue on warfarin, what is warfarin can cause the placental barrier and it acts as an anticoagulant in the baby. So that is having anticoagulant effects in the baby. So during the time of delivery, there is risk for intracranial hemorrhage in the baby. So that is why we stop heparin and shift to warfarin. Sorry, we stop warfarin and shift to heparin at the end of 36 weeks. So this is all about the coagulation failure in pregnancy. I hope you have understood the topic. In the previous video, we have discussed regarding the inherited conditions. So this is very important because coagulation failure that can be very fatal to the mother because it increases the risk for bleeding and a large amount of blood may be lost from the mother's body if not treated correctly. So I hope you enjoyed the video. Thank you.